Hello, my name is Harrison Stubbs. I am a third-year osteopathic medical school student at Kansas City University, and today I will be talking to you about de novo PR3 ANCA granulomatosis with polyangiitis in a healthcare worker after COVID-19 exposure. COVID-19 is a dangerous multi-system illness with consequences that are still being charted and explored. Post-COVID-19 syndrome is an uncommon diagnosis of exclusion that can present after 20 days and lasts on average up to 60 days. While symptoms lasting over 90 days are unlikely, it should raise suspicion towards ongoing complications, such as autoimmune phenomenon. For our case, we follow a 51-year-old healthcare worker with a past medical history significant for asthma, obesity, and tobacco use, presenting via televisit with complaints of sharp, throbbing chest pain associated with dyspnea on exertion that had previously been diagnosed as acute bronchitis at an urgent care 3 months prior, for which she was prescribed amoxicillin. Following this, she was recommended to go to the ER, where diagnostic tests and labs were inconclusive, and a acute asthma attack was suspected, and she was prescribed budesonide, formoterol, and albuterol inhalation. 2 weeks later, she followed up with the clinic with unabated respiratory issues, where she was referred to a pulmonologist who diagnosed the patient with asthma and prescribed Symbicort and albuterol. A week later, the patient came back with onset dysphonia and unresolved dyspnea. The pulmonary function tests were reordered, and the patient was diagnosed with GERD, as it can mimic symptomatology of asthma and be responsible for causing the dysphonia, dyspnea, coughing, and recurrent bronchitis. The patient was prescribed protonics, and labs were drawn for further investigation. 3 months later, the patient returned for continuing symptoms with additional hypoxic episodes and positional dizziness. Labs, vitals, EKG, and images were stable and within normal limits. An echo and ANA with reflex were ordered, and the patient was given a diagnosis of post-COVID-19 syndrome, for which she was consulted to infectious disease to follow up with. The patient returned, having not received a final diagnosis, and had new onset blurry vision, spasticity of lower extremities, despite the MRI showing no acute intracranial processes, and labs now demonstrated elevated CRP and anti-PR3 antibodies, for which the patient was started on low-dose prednisone. We are currently still evaluating this patient's response to steroids and evaluating further steps that may be needed. So for our discussion, granulomatosis with polyangiitis is an ANCA-associated vasculitis of small and medium vessels that affects multiple systems, but predominantly the lungs. It's a very rare or highly uncommon condition affecting 12.8 cases per million person years. It's rarely seen, and so is very often overlooked when establishing lists of differentials. And occasionally, the symptoms of granulomatosis with polyangiitis are very nonspecific and easily mistaken for general malaise, and this makes the diagnosis even more challenging. Being classified as an autoimmune condition, there are also a variety of etiologies that have been demonstrated to provoke these ANCA-associated vasculitis, such as Epstein-Barr virus, HIV, HCV, Staph aureus, cocaine, cigarette smoke, silica dust, to name a few, and now possibly the SARS-CoV-2 virus. The COVID-2 infects and activates neutrophils and generates an immune response to self-epitopes, such as anti-proteinase 3 and anti-myeloperoxidase, which may persistently reactivate for up to 7 months. These autoantibodies have been associated with the developments of myalgias, Kawasaki-like vasculitis, and vasculopathies, possiimmune glomerulonephritis, and de novo ANCA glomerulonephritis in COVID patients. Interestingly, our patient had 3 negative COVID tests despite being a high-risk exposed healthcare worker at the initial onset of her symptoms. However, it has been reported that asymptomatic COVID-19 patients may be less likely to develop COVID-19 antibodies, which may explain the 3 negative tests. PR3 ANCA is associated with Granulomatosis and Polyangiitis and is increasingly becoming more utilized for its clinical and prognostic value. And post-COVID-19 exposure patients should be followed to explore the changes in lab values for further knowledge. And in conclusion, COVID-19 exposure can result in the activation of autoantibodies that can result in an array of issues. These autoantibodies may linger for about 7 months at a time and can persistently give issues that are attributable to other pathology. One should begin to consider a rheumatologic cause secondary to COVID exposure in these instances. We postulate the occurrence of a post-COVID de novo granulomatosis with polyangiitis 250 days after the onset.